Hello, good afternoon. My name is Dr. Samir Dervisevic. I'm virologist working in Norwich, County of Norfolk, England. And I would like to talk to you about the impact of COVID-19 on clinical services in England. Before I start, I wish to thank the Menarini team for very kindly inviting me to give this presentation. Without further ado, I'm going to talk on the impact on acute clinical services in England, and then I'm going to concentrate on the impact on virology services in England. This is my own specialty and my own field of the expertise. And I'm going to divide the presentation into two parts. I'm going to talk firstly about the impact on acute clinical services very early in the pandemic, and then finish off by talking about the current services that are being provided. In terms of the COVID-19 pandemic, it is fair to say that it has delivered a profound shock to the clinical services in the United Kingdom. The government has made several measures with the ultimate aim to control the spread of the SARS coronavirus. And these measures have reached deep into people's life and affecting their job security, i.e. their income, affecting their social contacts, and finally, their access to national health services. And as you know, they're all factors that are essential to healthy lives. Pathology diagnostic services, and in particular virology, were initially unprepared for the impact of the pandemic and started almost for a very low level of preparedness. And in the meanwhile, since the start of the pandemic, virology services have undergone a very rapid change in real time and have been profoundly changed. So it all started in the United Kingdom on the 31st of January 2020, when the two first cases of SARS coronavirus 2 were confirmed. There were two people who traveled from Wuhan, province of Hebei in China, and were diagnosed in the north of England. A month later, the 5th of March 2020, there was a first death from COVID-19 recorded in the United Kingdom. At the same time, the total number of confirmed cases was 85. And from then moment in time onwards, the number of cases absolutely exploded. On the 12th of March 2020, the United Kingdom Chief Medical Officers raised the risk to the country from moderate to high. And on the 16th of March, because so many people are being admitted to intensive treatment units, the UK government issued a call to support of the supply of ventilators. At the time of the pandemic, National Health Service had access roughly about 80,000 ventilators, but it was thought that up to 30,000 ventilators might have been needed. And the year of 2020 finished by the start of immunization in the United Kingdom. It was December 2020. There was emergency authorization for use. First two vaccines have been authorized to use in the United Kingdom. I'm just going to give you the total countdown in terms of numbers and the latest COVID-19 situation in the United Kingdom. On the right of the slides, you can see that the total number of confirmed cases from the start of the pandemic has been 10,819,000. And sadly, about 146,439 people have succumbed to this infection. When you look at the slide tells you the recent cases, cases that were detected on the day. And because I took the numbers at the end of the week, usually these numbers are somewhat smaller than the reality. And you can see that on the 9th of December, when these figures were released, there were 48,000 new cases. And you can see that the same day there were 52 new deaths from COVID-19. and roughly 7,400 people were hospitalized due to COVID-19. The slide also shows you the total number of vaccines given in the United Kingdom. We are talking about 51 million, and underneath there's a breakdown in terms of boosters, people receiving first dose and second dose. This slide tells you about a breakdown of confirmed cases of COVID-19 in the United Kingdom in thousands, and is showing 3 waves of the pandemic. If you look at the very beginning from February to June, I think the numbers are smaller, although United Kingdom has a very stringent and comprehensive reporting strategy. All the positive cases are reported. Because of the lack of adequate technology at the very beginning of the pandemic, this number is probably not that accurate. But then with the second phase, you can see the number of cases were going up to 60,000 daily. And finally, now we are in December 2021, and the number of cases has been climbing up. The end of last week, on the 12th of December, 51,497 daily cases of COVID-19 were reported. So in terms of the impact of the acute services, the NHS was, under the guidance from the UK government, radically mobilized in terms to respond to the acute need of patients who were infected with COVID-19 infection. So this work to respond to pandemic was going alongside or delivery of ordinary services which were scaled back. I'm talking about services referring to non-COVID-19 healthcare. There was a serious direct impact of the SARS coronavirus in terms of death and serious illnesses among vulnerable patient groups such as elderly and patients with underlying medical conditions such as hypertension, diabetes, ischemic heart disease, and other chronic diseases. And I have to say that a large number of hospital admissions required intensive care treatment. There was an indirect impact of the pandemic on patients with acute conditions that were not related to COVID-19, simply because some people decided not to report to hospitals, although very ill, because of the fear of contracting COVID-19 infections. In March 2020, NHS trusts, so this is the 3rd month of the pandemic, NHS trust hospitals, they rapidly redesigned services on a large scale in order to create capacity to treat patients admitted with COVID-19 infections. Part of the strategy was to discharge thousands of patients in order to free up beds. Planned treatment was postponed for many patients, and where possible, outpatient appointments were shifted and became via telephone or online. For instance, I'm involved in viral hepatitis clinics, and we stopped seeing patients face-to-face. And currently, now we are in December, roughly 50% of patients only are seen face-to-face, and the remaining 50% of patients are consulted over the telephone or online. Staff in the National Health Service were redeployed, and the NHS issued more than 50 sets of guidance to hospital specialists regarding the treatment of non-COVID patients during the pandemic. By April 2020, there were concerns about the significant drops in use of accident and emergency for urgent conditions. Admissions for stroke and heart attacks, for instance, dropped. There was a report by British Heart Foundation that about 38% of drop of emergency heart surgeries in London, which is one of the biggest centres for heart surgery in the United Kingdom. As I mentioned, patients were staying away because of worries about contracting COVID-19 or trying not to add further pressures on the National Health Service. The slides here depicts the impact of acute services, and in particular on the accident and emergency. So if you look at the slides depicts the number of visits to A&E from April 2017 to April 2020. And you can see that the major admissions and all A&E admissions, they have been reduced 50% from January 2020 to April 2020, i.e. significant drop in number of admissions to acute services. There was also an impact on the primary care or family doctors, or GPs as we call them in England. The National Health Service issued guidance to protect GP services and patients and introduce a great deal of changes in the way GPs were operating. The changes were mainly along the line that the assessment of all patients was via telephone initially, and seeing the patients in GP surgeries face-to-face only when necessary, and also setting up dedicated hubs to manage suspected COVID-19 patients. The NHS digital data showed a 30% fall in the overall number of appointments to primary care, to GP practices in England in March 2020. And the drop in face-to-face appointment was offset partially by a rise in telephone or online appointments. I need to say that general practices in England, they do much of the work managing patients with chronic conditions or people needing less urgent care. These are the people who don't need acute admission to hospitals. To free up capacity, general practices were given the option to defer routine activities such as health checks for certain patient groups, such as elderly people aged 75 years or older, and from conducting routine medical reviews. At the same time, the public were given instructions to call a National Health Service 111 telephone rather than contact their family doctors, GPs, if they develop COVID-19 symptoms. And GPs started managing the patients whose planned surgery, for instance, orthopedic operations, were postponed. And at this time, there was a real worry about reduction of early detection of cancer. I just want to mention that if there's any fear of possible cancer in a patient, the patient can access specialist care, or they should access specialist care within 2 weeks. And there was a worry that this number was significantly reduced. Looking at the impact on the primary care and the face-to-face GP appointments, you can see that from April 2019, the number of these appointments has dropped, and the number of telephone and video conferences, and this is graph in blue, has increased for the same period. In terms of managing of people with a considerable vulnerability, these are the people who have significant underlying medical conditions. At the beginning of 2020, in March and April, the NHS England identified over 2 million of people with considerable underlying medical conditions, and those people were given advice to shield. By February 2021, the number of people, CEV population, has increased to 4 million. And if you look at the slides, and the difference in accessing elective procedures in hospitals and emergency procedures, the red refers to year 2019, and the blue refers to COVID year 2020, you're going to see that the number of elective admissions for cancers, digestive problems, genitourinary problems has dropped. Similarly, numbers of admissions because of respiratory emergencies, circulatory heart emergencies has also significantly dropped for this very vulnerable population. In England, there is a referral to treatment right for all the patients to see respective specialist, and the patient should be seen within 18 weeks. They shouldn't be waiting more than 18 weeks. And if you look at the chart here, the colors depicts different years. So in pale blue is the April 19, then April 20, and in black is April 21. You can see that number of referrals to treatment has significantly dropped for respective specialties. For instance, if you look at the trauma and orthopedics, you can see that the number of referrals has dropped to less than 50%, and so on and so forth. In terms of the impact of the number of people joining the referral to treatment waiting list, you can see that in April 2020, this number has dropped significantly and just only slowly started to recover over the period up to now. Similarly, there were almost 6 million fewer referrals onto the treatment waiting list. And you can see that in April 2020, according to the King's Fund, this number of referrals has dropped significantly comparing with the figures in 2019. I'm just going to move on and talk about the impact of the COVID pandemic on diagnostic services, and I'm going to dwell on virology, which is my own specialty. From the very beginning, we were following the situation in Wuhan in China, and virologists in the National Health Service, as well as those working in a public health England, were aware of the pandemic and its spread. I must say that majority of the National Health Service virology or microbiology diagnostic laboratories did not have adequate capacity to respond to this pandemic at the very beginning. And this was for issues such as technology, diagnostic platforms on assays, tests were mostly not available at the very start of the pandemic, and a majority of departments were inadequately staffed. From the time, virology services have undergone a tremendous change within a very short time to be able to respond to new demands from the NHS England. There has been training and making sure that we master new technologies in order to rapidly respond to instructions from the NHS England, NHS Improvement. So the slide just shows some of the diagnostic platforms for the COVID-19 in my own department. So since the beginning of the pandemic, the number of instruments has significantly increased. I'm just going to show you some of the numbers illustrating the pressure on diagnosis, daily diagnosis of COVID-19. So my own department is testing samples collected from the whole the county of Norfolk in east of England, and we are testing the samples collected from 3 university hospitals in Norfolk. If you look at the chart, the blue lines are showing the total number of tests. From the start of the pandemic, you can see that the numbers have increased, and sometimes there were peaks exceeding 1,600 samples tested daily. The yellow line is showing total positivity. So you can see that the numbers have remained steady, numbers of tested, numbers of samples have remained steady over the long time. The next slide is showing the total average daily COVID PCR activity. And if you look at situation now, the end of the November, December, over 1,000 samples are being processed on average weekly, and the red curve signifies the average daily positives. This is the slide that shows the total weekly number of COVID-19 positives. And you can see here the three peaks, three phases of the COVID-19 infection in England, and the number of positive, total number of positives. Laboratory RT-PCR technology is just one part of the diagnostic or testing of the samples, but it became very obvious that we needed additional help in order to timely diagnose COVID-19, and therefore we introduced the point-of-care testing and point-of-care platforms. They're platforms for rapid diagnostic technology with the results available between 70 and 90 minutes. There was a centrally organized deployment of these machines in the second half of 2020 and first half of 2021. And now every trust in England has point-of-care platforms at their disposals. There's an obvious benefit of having rapid diagnostic technology, and this is for triaging acute admissions to hospital via accident emergency, aiding hospital infection prevention control services, trying to minimize the intra-hospital spread, as well as faster discharge to care homes. All of these new technologies needed verification before their clinical use, and that's what we've done for all technologies. So some of the technologies that we are using in Norfolk in the three acute hospitals are Samba PCR platform, or the Liat Roche PCR platform, and you can see different colors denotes different hospitals. Norfolk and Norwich University Hospital is in blue, Queen Elizabeth Hospital is in red, and green is James Paget University Hospital. You can actually see that the number of tests on the point-of-care platforms has increased over the time, both for Samba test and for the Liat tests, i.e. they found a clinical use. We also started using another technology, which is the loop-mediated isothermal amplification. And you can see that there has been an increase of usage of this technology. Now, this technology requires, rather than using nose and throat swab, requires saliva samples to be tested, and it is currently confined to testing of healthcare workers. They are regularly tested twice a week in order to make sure that they come to work non-infected. And you can see that currently daily more than 500 samples are being processed. You are all aware about the issue with SARS coronavirus, that it is an RNA virus that mutates quite fast. So the slides here depicts the differences in the spike protein between the Delta variant on the left-hand side, or B16172, and the Super Delta, or AY4.2. So there is a need to keep abreast, to be aware of constant changes in order to be able to accurately detect SARS coronavirus. From the very beginning, there has been a great deal of impetus on sequencing on all positive samples in the United Kingdom. And the slides depicts the percentage of samples that were sequenced. So I work and live in the east of England, and in 2021 and the end of 2020, up to 36% of positive samples were sequenced locally, and majority of the regions in Pillar 1 testing, i.e. testing in NHS. About 5 to 7% of all positive samples were sequenced with an idea to keep awareness about prevailing strains circulating in the community. These are some of the results of genome sequencing from the samples that were processed in my own department. If you look at the right-hand side with the B117 or the alpha variant or the Kent variant, that was a strain that was replaced by Delta variant in January 2021. The green bit is B11198. It was a strain that was depicted in one of our poultry factories. There was an outbreak, and if you go further to the left, with the orange color, B1177 was the Spanish variant that was introduced repeatedly in the United Kingdom in 2020, following people returning from holidays. Now, the genome sequencing has helped us, has allowed us to often pinpoint the outbreaks and also to be aware of strains that were circulating, which has a particular importance for the vaccines that are currently used. These are some of the results of the sequencing of the positive samples from my department when compared with what was circulating in the United Kingdom. Again, making sure that we are aware of the strains and also making sure that we could help our clinical services in order to diagnose outbreaks. Finally, from the April 2021, the NHS England and the Public Health England has asked every virology laboratory to start testing, genotype testing for variant of concerns. This is something that we do every day, 7 days a week. And currently, you're aware there is a new variant circulating. There's an Omicron variant, which has about 30 mutations in the spike region, some of the cardinal ones being K417N, also N501Y, and deletions such as 69.7 deletion. So we are currently testing, as I said, on a daily basis, and this slide just depicts the Omicron variant being diagnosed based on detection of K417N mutation, also deletion, 6970 deletion, and one of the mutants such as P681 are not being detectable. So I just want to finish at this stage and just to say that it has been a tremendous journey. The current pandemic, SARS-CoV-2 pandemic, has delivered a profound shock to the United Kingdom health services, and this shock is still reverberating. There was a resulting impact on primary, secondary, tertiary care. There were several changes that were highlighting the importance of quick reorganization and adapting to circumstances. Virology diagnostic services, which are pivotal for making sure that the cases of COVID-19 were detected, have undergone a rapid change. And the lessons that we learn will help us to tackle future pandemic, because I'm sure there will be more of these to come. That is all. Thank you very much.